Well, thank you, Mr. Chairman, and thank you, Ranking Member Murray, as well, for holding this hearing. Thank you to all of the witnesses for being here. We really appreciate not only your presence, but your expertise and your commitment. As you know, New Hampshire has been especially hard hit by the opioid epidemic. And we also have many patients who are suffering from chronic pain. So we need to make sure that all of our patients have what they need to access care, including those suffering from pain, as well as people who are suffering from addiction and mental health conditions. But provider shortages in all of those areas is a real issue in my state. For example, Dartmouth-Hitchcock, which is the largest healthcare provider in New Hampshire, has between 750 and 800 open positions at any time. And the state's community mental health centers have more than 175 vacancies for clinical positions. So this first question is to Dr. Koop and Dr. Gazelka. As faculty of pharmacy and medical schools, I'm interested in what you see as the greatest workforce challenges and your views on the role graduate medical education plays in training the next generation of physicians. And the follow-up to that, you can answer both. How could additional residency slots, particularly in fields like pain management, addiction medicine, and addiction psychiatry, improve access to care for patients? So Dr. Gazelka, if you'd like to start, and then Dr. Koop.
I think it's probably not a popular thing to talk about, but I think the cost of medical school and the loans that students accumulate during the time that they're in their medical training are cost prohibitive in some cases into going into some of the primary care practices and some of the lesser reimbursed practices, which may be such as, primary care, psychiatry, addiction medicine, et cetera. And I think that's a real problem. I remember at the time that I was in medical school at the University of Minnesota, the dean came and spoke to our class and said, so many of you are planning to go into specialties, you need to go into primary care. We need primary care physicians in Minnesota. But at the same time, the University of Minnesota Medical School was the most expensive state medical school in the United States at that time. And those considerations have to be taken. And so I think finding some way to encourage students to go into specialties that are needed would be important in that regard.
Thank you. Dr. Koop?
Approaching this specifically from pharmacy, pharmacists, as I mentioned, are often the most underutilized of healthcare professionals. They are the medication experts.
Yeah.
They are. I teach them all about drugs. They're also taught how to counsel patients, how to appropriately counsel patients with medications. One of the biggest issues we have with patients taking medications is actually taking the medications. Right? Mm-hmm. If the medication doesn't get to the patient, it's not going to do any good. So again, part of the financial model, though, is reimbursement for those cognitive services. And it's getting those reimbursement for those cognitive services could bring the pharmacists into that healthcare team, which would expand that access you're talking about.
Well, thank you. And that brings me really to my next question, which was about reimbursement, and again to Dr. Gazelka. We know it can be a powerful tool to influence the availability of services as well as providers' behavior, and that the lack of appropriate reimbursement, to Dr. Koop's point, it can create tremendous barriers for patients who need access to a variety of services. Insufficient reimbursement policies in federal programs like Medicaid and Medicare, as well as in private insurance, can sometimes create barriers to access to therapies and services that can reduce opioid use, including chiropractic services, some surgical interventions, acupuncture, behavioral health programs, and multimodal pain strategies. We've taken in Congress some important steps over the last few years, both in CARA and the Support Act, to help address some of these barriers, and certainly Dr. Ro Patel talked about things that Blue Cross Blue Shield is doing to try to eliminate some of those barriers. But Dr. Gazelka, can you give me some specific concrete actions that Congress can take related to reimbursement in order to improve patient access to non-opioid pain management therapies and services?
I am an interventional pain physician, and so I do neuromodulation. I implant intrathecal drug delivery systems, spinal cord stimulators, et cetera. In many cases, it is very difficult to get those covered. I find that Medicare is one of the most difficult when I have a patient on Medicare to have access to those therapies. Those therapies are proven in Europe to be extremely useful for chronic angina, for instance, so that patients don't have to pursue further stent placement, et cetera, or use opioids for chronic headaches, but the coverage for them is poor. I also think that I have rarely met a patient who wouldn't benefit from behavioral and psychosocial management. It's vital that we treat those areas for patients, and they're not covered. In the hospital, we'd like to allow patients who are having surgery to have access to non-opioid management. We did a survey recently at the Mayo Clinic showing that 94% of patients would choose something other than opioids acutely after surgery if they could. But we can't provide acupuncture, we can't provide massage, we can't provide extensive physical therapy at sometimes and restorative therapies for those patients.
Thank you, and thank you, Mr. Chair, for your
Thank you.
indulgence.
Thank you, Senator Hassan. Professor Cassidy.